Hello and welcome to this joint webinar hosted by Care Control and PainChek. We're here today to discuss how AI and digital technology support improved outcomes in dementia care. I'm now going to hand over to one of our hosts, Marcus Stevenson. Over to you.
Thanks, Alicia. Hello, welcome to our webinar. This is distinctly about our AI technology, digital transformation, and how technology works within the healthcare. So it's great to have everybody here. We're hosting, I said, Care Control are hosting today. We've got a number of guest speakers on with us. So I firstly want to quickly whiz through who we've got on the line. We've got obviously myself, Marcus Stevenson, as I've been introduced. We've got Tandeep, who's our head of business, not for us, but for PainChek, head of business development for PainChek. We've also got Zeta, who is the operations director for Angel Care and M&S Care PLC. And we're also joined by Paula Cashmore, who is an independent care quality consultant, but Paula has also recently opened up her own business, which is called the Achievable Care Quality Community. So it's fantastic to have these people with us on today's call. We're going to run through, as we talked about, the impact of AI and digital tech in dementia care. Really important. Paula and Zeta are going to have some time talking a little bit about how that tech care has been adopted into the Angel Care and M&S Care itself, and that's going to be quite interesting. So I think stick around for that. It's going to be some good debate in there. And then we'll close out by talking about how AI and digital tech really supports the CQC standards and the quality statements. And then we'll have some potential Q&A at the end and some closing. So hope that frames it for you guys today. Really great to have you all here, and really excited to talk about what we're going to be delivering today. So I want to introduce Tandeep, and Tandeep's he's a big boy. He can introduce himself. So Tandeep, welcome to the webinar.
Thank you, Marcus, and I'm delighted to be here to, I guess, share what we've done at PainChek, but also the unique integration we have here with Care Control. So look, my background is from a clinical background. I'm a pharmacist, but at the moment I'm heading up business development here at PainChek, and I guess PainChek is one of the first successful uses of AI technology in the care sector, and I really want to kind of hone in on this and share with you actually what is PainChek.
Fabulous. Listen, exciting sector as well, right, for you guys, and a lot of growth at the moment.
Yes, absolutely, and we'll cover this off in the webinar in terms of what our growth has been like, but essentially how we're actually delivering really good outcomes through the use of the technology to help enable carers deliver better dementia care, and that's really the focus for today. So look, what is PainChek? PainChek, I guess, is used to address the fact that pain is difficult. It's difficult to assess. It's difficult to monitor, even more so for people who cannot verbalize their pain. So our purpose here at PainChek is to give a voice actually to people who cannot reliably verbalize their pain, such as people living with dementia, but also that extends to people that are living with learning disabilities or accessing mental health services, essentially anyone who's lost the cognition to be able to share they're in pain. And we know currently there's some challenges with pain management and pain assessment across the sector, and PainChek aims to address some of them, and we'll cover that off on the webinar now. But look, PainChek is a mobile app, right? It comes in the form of a medical device, and I guess this is where it becomes really fascinating, because PainChek uses a combination of AI and human intervention. So the AI element uses a camera on the smart device to identify facial movements that we all have when we're in pain. But actually for people living with dementia, these movements are more heightened, so it's more sensitive. And the AI is then combined with the human intervention, and essentially that guides the carer through what we call a checklist of other pain indicators. We look at the voice, the movement, the activity, behavior, and body. It's a multidimensional approach to pain assessments. And essentially that tells us then how bad the pain is in the form of a severity score. The process is rapid, it only takes a couple of minutes, and pain scores are actually documented not just at the point of care within the app, but also within an online analytics and evidence portal. But we also recognize the importance of data consistency, data integrity across different clinical systems, which is why we're proudly integrated with Care Control, where pain data moves seamlessly into Care Control and essentially helping multidisciplinary teams, care staff with, decisions, supporting those decisions, essentially. But all in all, with 4 million assessments now completed globally using PainChek, it just shows how well the technology is being used. And we believe it's due to the simplicity of the PainChek system and essentially removing guesswork and subjectivity from current practices. And I know Zeta and Paula here today will be sort of exploring this a little bit more. But before we go to that, just to sort of set the scene, and in terms of how PainChek has been well documented across the sector, we've seen that there's been several peer-reviewed validation studies completed by PainChek. Clinical practice papers have also been made available to clients. So there's some real evidence behind this. But we've also seen our regulators now taking interest in PainChek, and interestingly, the CQC have recently documented PainChek outcomes in their innovation hub, but also referencing it in their state of care report, which highlights how PainChek has enabled successful use of AI technology, specifically transforming dementia care. So hopefully this sort of sets the scene for the session today.
Thanks, Tandy. And just fantastic, right? Some really good numbers in there, some fantastic benefits. And this is all off your mobile device, right? So I think in terms of ease for the layman, and if you've not seen this before, again, it's another mobile application, which is straight out. Use your mobile device, tablet device. It's there. It's so simple and convenient for the end user. So thank you. So thanks, Tandy. Just covering off Care Control, right? So obviously we're hosting today. Why are we here? Who are we? And a little bit about the features of what we do as a business. So Care Control itself, we understand, and we've for a long time now, a number of years, recognised that the journey that we go on through life is unique. It can sometimes be full of challenges from a healthcare perspective. And at times we are going to need that help. Somebody's going to need to care from us. And so for us, it's really important that you have your choice in where you receive that care, first and foremost, and that you have the best. And our solution is very much about utilizing digital technology, which makes sure that that care is delivered in a personalized way, right? So in terms of an offering that we're able to give you as the client, as the resident, we're here for everybody. We want to make sure that people have support throughout those different critical health stages that we're all at some point going to experience. As a business as well, it's really important to recognise that Care Control itself, we're backed by the NHS. We are an assured supplier. So we are scrutineered. We are put through the rigorous process of making sure that our products and our solutions are basically rubber stamped by the NHS and that we are in that assured programme. The product that we provide, the Care Control system, it's all in one. It covers a multitude of facets that are going to be important to your everyday care. And again, we'll cover that off as we move through the sections. Most of this, people go, well, how much is it? It's cost. It's going to be extra money to digitize. Well, obviously, we're looking to make sure that people save on their solutions and moving particularly through from a non-digitized solution. So if you're running on paper, that in itself can carry huge expense. So we want to make sure that we are looking at how we provide those solutions around savings, not just through capex costs, but also through efficiency. It's less admin. It's one of those things that I think many care homes see the realization when they change and go digital, that suddenly they see this huge amount of money that they've been spending, but not just the money, the time that they're able to put back into their patient care. So for us, it's hugely important. Our product's fully customizable. We work with our customer base to make sure that the product is fit for them through the training and implementation programs that we offer within the onboarding process, and throughout the support and life cycle of their particular customer journey. We do trend analysis. We have our analytics dashboarding, which again helps carers to deliver the right level of service, to maximize and capitalize on things like compliance, and to make sure that when you're being audited, the information is there at your fingertips. So as a system, yeah, absolutely, we're here to help support both customers that want to turn to the digital process and those existing customers that we already have on board. So I hope that outlines Care Control and who we are. So I'd like to introduce Paula Cashmore. I would say, Paula, you need no introduction, right? So you are, as you rightly say, the Mary Poppins of Care. So listen, I thought it'd be interesting, Paula, you introduce yourself, say hello to maybe the people that aren't familiar with you and those that are.
Thank you, and thank you for inviting me to participate in this webinar. I'm really keen to encourage digitisation in social care. I think it has amazing benefits. I am a registered nurse. I've been in social care for 40 years. I adopted the name of the Mary Poppins of Social Care when somebody said I'd got a lot in my bag, and that's probably because of the various roles that I've had, from nurse. I've even been a carer when I dropped my registration. I've also done NHS inspections. I've been a registered manager. I've been a regional manager. But I've also got various voluntary roles. I work with the Voluntary Care Professional Register. I also work with Prince's Trust as a mentor, employability mentor, and with NACAS, the National Association of Care and Support Workers. So, as they say, a lot in my bag, but I'm very keen to work with providers and ensure good quality and good care, because you can have good care without actually ticking the boxes and not being able to evidence for CQC. So having really efficient digital systems to support that evidence is important to me.
Paula, you sound like you're extremely busy, and that bag, it must be huge, right? It must be huge. So it's great to have you on the call today. Thank you so much for joining us. Fantastic.
Yeah.
Let me introduce you to Zeta. Zeta's our operations director for Angel Care and MMS Care. So I'm gonna say, Zeta, welcome to the webinar.
Welcome. Thank you very much for inviting me to take part in this. I feel really passionately about digital care and making sure that our residents are advocated for. And one of the best ways we can actually do that is by making sure that we've got the appropriate tools in our toolkit. So I am a registered general nurse. I'm a registered mental health nurse, and I have a master's in nursing as well. I have been in social care in various guises since 1991, 92. I've been a nurse, I've been a deputy manager, I've been a registered manager, I've been regional compliance managers, I've been a quality manager, I've been an operations director, and I'm also the nominated individual at CQC for this company at the moment. So I have quite a wide specialism. I consider myself to be a psychiatric nurse, a mental health nurse first and foremost, and Paula will probably attest to that's very much how I tend to think. So I'm very much for advocating for people who can't speak for themselves, who are not able to speak for themselves, or who are disenfranchised from society or the care pathway. So it's something that I hold quite passionately about, making sure that we deliver the best care, even for people who can't necessarily communicate that care. Or something that I picked up from earlier with what Tandeep was saying, in that people who don't always want to own that pain because they're either very stoic, or they're the war generation, or they don't want people to see them as weak. So sometimes people can articulate their pain but choose not to. And that's why PainChek is such a great tool, because it helps us overcome that as well.
Thanks, Zeta. Fabulous to have you. I feel a little bit humbled, actually, given the level of knowledge and experience that we've got on the call with us today. And again, I'm not from a care background. in my history. But again, it's great to have such fabulous individuals who've got such great knowledge with us today to talk about that. So thank you. Great to have you here, ladies. Thanks for joining. So let's move on then and talk a little bit about how the AI and digital transformation technologies help us in dementia care. Obviously, we've got Tandeep here. Tandeep, we've got some really good figures on here. Do you want to explain a little bit more about your expertise and about the dementia side of PainChek?
Yeah, thank you. Thank you, Marcus. That's great. So look, I guess the statistic that I'm going to share with you is, many of you may know this already, but a UCL-led study recently highlighted that the number of people living with dementia is set to sort of double to 1.7 million by 2040. And I guess, that's a figure that's quite worrying, actually, and quite troubling. And it's going to have an impact, right, on not just people living with dementia, but their families. And I guess not to mention the impact that will have on an already stretched health and social care workforce. So I think we agree collectively, right, that we need to be innovative in our approaches. So whether that's the use of technology, whether that's changing the way in which we work as well. So it's not just technology. It can be how we educate our people that are essentially caring for others. But I think we agree collectively, we've got to really help people care better for other people, And look, 5 years ago, AI was really in its infancy, and a lot's grown in that sector. And I would say, on personal reflection, having worked in the NHS, AI has been around. But I think social care has got a massive opportunity here to take the learnings from NHS and it should bring that into social care. And let's do things really well with AI. And hopefully, through this session today, I can sort of relay some of the fears around AI as well. And I speak to people regularly about the AI element, and one of the biggest things that comes out from it is that, is AI going to take away our jobs? And I think where AI is best fitting in the sector and how it should be introduced to the sector as we bring more in, and something we've learned here at PainChek is really to actually leverage AI, but not replace the individuals, not replace the carer. In fact, aid them, help them, and in terms of with pain, helping them with the process of assessing pain, not actually replacing the face-to-face interaction with the resident. It's social care for a reason. You're not going to replace that face-to-face interaction within the sector. That's so we feel this is the best way to essentially bring AI into the sector. And look, where can AI help? Well, from a carer perspective, it can help take away those burdensome tasks. It can support with better decision making. And in particular with PainChek, our aim is to empower carers, regardless of their clinical background, to consistently identify pain. So these are some of the key areas I think we really need to explore when bringing AI in. But it's not just artificial intelligence. It's education. It's the use of data and analytics. But it's also important that we have really good integrations as well, so that the AI is integrated with other digital clinical systems as part of that whole, care technology ecosystem, essentially. So for me, there's a few points I want to share today around sort of the integration that we've got with Care Control. And I think collectively, Marcus, I think you'll agree, right? When we set out on this journey together, I think the first thing we talked about was really to make it easier to care for people.
Absolutely.
Right. And when it comes to pain, essentially ensuring that families also feel reassured that their loved one is comfortable and not in pain. So I think these are some of the key aims that we want. And look, how can we do this? Well, better documentation is important. It's important for many reasons. Of course, from a quality and governance point of view, it's important, but also from a communication point of view, and being able to learn from what you're doing day in and day out and reflect on your practices. Documentation is really key, you know. Automation of processes. I mentioned earlier about removing tasks, making tasks quicker. If we can automate many processes, we're freeing up time for care. That's really key here. But also, when it comes to PainChek being a medical device, it's also important that we've got the right data and we're digitally supporting diagnosis as well at the same time to make, I guess, to help clinicians, to help MDTs make better decisions. And, you know, it's what Zeta mentioned earlier around people not being able to reliably report their pain means that often poorer decisions are made on someone's pain levels or pain management. And actually, here's a tool that can really kind of help with that, you know. And that's what we're seeing. So by accurately monitoring pain, supported with our integration with Care Control, we will see profound outcomes. And, you know, some of the outcomes we're seeing for residents at the moment, which it has to be front and center, is that, you know, we're seeing reductions in distress, you know, up to 40% in many case studies. Falls are reducing as well because people are not in pain. They're not as, you know, they're more mobile. They've got a little bit more confidence to walk because they're not in pain. It's that fear of falling, essentially, that relates pain to falls. But a large client recently reported a reduction in serious injury up to 91%. And people are on less medication and the right medication, namely psychotropics and analgesia. So these are sort of key areas that we're focusing on and getting some really good outcomes. So we want to do more here. We're just touching the surface. And I think, you know, through the integration we have and the work that we're doing with Care Control, we're aiming to really transform the way in which we deliver dementia care. And I think it's a really exciting prospect.
Sandeep, there's a couple of bits I love there, right? There's two key buzzwords, I think. First one is about interacting, right? That for me is massively important because, you know, that's what healthcare is about, isn't it? It's about getting the time, the opportunity to spend time doing the quality care. And the other word you use there is about empowering. You know, it's just about empowering both the staff, the individuals, giving people the confidence in this AI, right? Because that's a key thing to overcome, right? People going through new technology. And I'm sure Paula and Zeta will give us some insight around that in a minute about how we've integrated, how that worked for them. But those two areas are really, really important. And the key figure you said 91%, right? 91% reduction in falls or accidents. I mean, that's significant. That's a huge transformation in terms of using this piece of kit and you know, helping people to have less time. I mean, less documentation, less inefficiency in their workplace, and more time back on patient care. So that's got to be an amazing thing. So I think for me, those takeaways are fantastic. So thanks for sharing those. So I'm going to hand over to Zeta and Paula to have a little chat. So Zeta, you're going to kind of talk a little bit about, you know, you've gone through this process of integration, be it with Care Control customer using our product, and then the integration with PainChek. So it'd be really good to hear a little bit more about how that's been for you. And I know Paula and yourself have had some great experiences. So I'm going to drop the mic a minute and hand over to you two.
Thank you. When you try and roll out a new app or device or method, and I'm sure Paula will agree, sometimes you get a little bit of pushback from the staff because they feel that it's another thing that they're being asked to do. And one of the ways that we combated this was to try and get people on board, to try and get them to understand that this that you're going to have to do, and and if we get this right, it will mean that other things that we're having to do will sort of drop off. So one of the things that Paula and I have talked about is that how sometimes unrecognised or undiagnosed, or as I said earlier, unowned pain can sometimes cause the residents to act in distressed ways, and sometimes we don't understand what the cause of that distress is. Quite often it's been found that it has been undiagnosed pain, and one of the things that PainChek allows us to do is to rule that out. It's not only just ruling it in, it's ruling it out. So one of the things that has been quite difficult for people to understand is that the old pain charts that we used to religiously use, that this has been built upon, that PainChek has been built upon, is very subjective. And we're finding in practice that the subjectivity is removed by using the PainChek tool. What do you think about that, Paula?
Think, you know, we agree on a lot of things, Zeta, and that's very important. And again, from my perspective, while looking at quality in care, that will match with a lot of the CQC quality statements, the, you know, medicines optimization, the learning culture, as in you're learning about your residents, safe systems and transitions, effectiveness, assessing their need. All these are really basic things that CQC are trying to capture, and you've got those in electronic evidence when you're using PainChek.
Do you think, Paula, that fits very well into the new quality statements under the new single assessment quality framework that CQC are partially rolled out across the country?
Yes, I think in looking at everything, all the evidence that we have been talking about, let me count the amount of quality statements. There are 8 safe statements that and out of the 8 safe quality statements, it fits into 4 of them. Out of the effective, there are also 4 that it will fit into. There are 5 caring statements that it also covers. It covers 6 responsive statements and 2 of the well-led statements. When you've got one digital app that covers so many of those quality statements, it's easy to see what benefits AI brings to dementia care.
I think one of the things that is really interesting is that even though we're talking about dementia care, it's far, far wider reaching than that. Because as I mentioned earlier, there are some people who don't want to own their pain for whatever reasons, whether that's personal reasons, pride, they don't want their family to know that they're suffering, religious reasons, spiritually reasons, or that's just how they've been brought up, that we don't complain, we just get on and do. And one of the things that we have noticed is that this is picking up that pain level, and then it's how then we as skilled practitioners and how we empower our nurses to be able to have those clinical conversations with those residents and with the GPs in cooperation to make sure that their prescribed analgesia is correct, it's not too strong, it's not too mild. And then what we found from when we're doing regular pain checks on people is, I'm a bit of a stats and an info geek, as Paula knows. I love looking at these types of things, but it gives you a nice visual representation of what the pain is doing for that resident, and that can be shared in care reviews with relatives, residents, GPs, the mental health team, or the CHC team for reviewing NHS funded elements of care. And it's a very clear indicator of what their pain is doing. And one of the things we've started to look at is, if their pain is settled and constant, do we need to review the analgesia? Because maybe the analgesia that they're having is maybe too strong, and we can review that. And that goes hand in hand with reducing the other symptoms that some residents can have as a cause of having to have a strong analgesia. Would you think that is fair? Or
Yeah, I mean, it does. It incorporates so many things, doesn't it? And one of the effective quality statements where staff teams work together, is to work effectively across teams to support people, making sure they only need to tell their story once. And when you've got that data that can give that information to GPs or to hospitals, then that covers the fact that that resident doesn't need to be sharing and discussing their pain all the time.
I think this is really important because both Paula and I are very strong advocates of working collaboratively with everybody across the health and social care network. And we are quite proud to champion social care as being the excellent care provision that it can be. And Paula and I do feel very strongly about this. And we are forever trumpeting that we work in social care, and social care is great, and social care needs to be recognised for all the great and wonderful things that we do. And I think the incorporation of this type of technology is clearly demonstrating that we're willing and we're wanting to develop and to provide a good, rounded, holistic service for those who are in our care, and that by sharing the information that these tools that are not subjective have gleaned and given us the data to be able to really clearly evidence that we are treating the person as a whole. And when you think about the CQC I and we statements and the I statements, that are the statements that are coming from the resident, it is very much about them having a control and an empowerment and an integration with their care across their entire care pathway. So as Paula said, it gets very repetitious where you have to keep saying the same thing to everybody all the time. And we're hoping that this new framework and the development of that will assist residents to be able to have a seamless journey through, across, back in, through and out of health and social care providers and services. And what we have found is that because it is on a handheld device and it is an app, because we use Care Control and we have Care Control on our handheld devices, they're not having to carry something separate with them. They can be both loaded onto the same device. The Care Control system allows us to set alerts that are bespoke for each individual resident depending on their pain need. So we can set up as many alerts for us to check somebody's pain as we want. We can do more than that. And anybody and everybody can use it. We've moved away very much from the nurses doing it at the medication round to the care staff and all staff doing it at any time. And I think that's when it's really important, because once you've got the consent within your residents' folders, files, care plans, care control, to assess them and treat them for care, the PainChek can be used so seamlessly in a group environment without them being singled out and having to sit there at the table and ask the resident, are you in pain? They're not going to want to necessarily own that in front of their resident sat at the table in front of them. So it's not the most dignified approach. Being able to do the PainChek discreetly, as long as we've got consent, it gets rid of a lot of that as well if you're just using certain elements of it. And I think that's really, really powerful, because people don't necessarily want to own their pain. And nurses, Paula and I are nurses, and we can say this, do sometimes have a habit of asking questions when it's not the most confidential or dignified area to ask those questions. What do you think about that, Paula?
Yeah, and I think, like you said, about people that can't articulate or won't own their pain, again, CQC are looking for equality in access and treating people person-centred. So it's not just dishing out paracetamol 4 times a day or even stronger painkillers because previously people have been in pain. You can check, so it helps the whole NHS from a prescribing point of view, a GP time, practice nurse time, all of those things, and especially in social care, giving that individual assessment. And your point about anyone can do PainChek, with it being with the carers, again, you are empowering your workforce, you're encouraging development, you're encouraging knowledge. So, you know, good use of AI is essential to have a well-trained workforce.
And I think moving on from that, Paula, as well, is I know that we've discussed this previously, where we have some, obviously coming from a mental health nurse perspective, we have some residents who, when they're admitted to our care homes, have a lot of medication prescribed, and quite often it falls to the care home to sort of go through and review that as part of the new admission process for the resident. And there's quite a lot of residents who are prescribed multiple medications that we're not quite sure what the indication for those are.
Mm.
And one of the things that we've anecdotally started to pick up is that some of our mental health clients are prescribed quite strong analgesics, and we're questioning where and what that is actually for. And there is a question around whether or not they're wanting to have those medications to self-medicate for their mental health needs, or because they've got they've got used to them and they can't live without them, and it's something they have made their mental health concerns into a physical concern, and that's how it's manifesting themselves.
And that knock-on effect again is, as CQC says, we want to support people to live healthier lives and to manage their health and well-being. And so again, you're looking at the quality statements and effective use of the analgesia, of the medication that people need, because they specifically say in the quality statements, where possible, reduce their need for care and support.
I think one of the things anecdotally that we're starting to find is that when we've got a body of evidence that we can present, we can quite clearly question whether or not this analgesia is prescribed at the appropriate level, and whether that can therefore be reduced, and we can look for other ways and attempts to manage their mental health needs, be that different type of talking therapies or different types of support within the care setting, to help to wean them off the dependency that some of the people have had through strongly prescribed analgesia. And then conversely, at the other end of the health and social care scale, where you've got people who are at end of life, where you wouldn't be even considering really dosing. Your main aim is to make them comfortable and content and relaxed. And again, I haven't used this in reality, but I'm hoping that we will do at some stage, that we would be able to very, very clearly evidence if their end of life pain management isn't appropriate, and we might need to have that upped. And I think it will be really powerful in that. We haven't managed to do that yet, and I'm hoping that if we come back and revisit this so many months down the line, that I might have some evidence that might have happened as well. And I think that's going to be really powerful, because end of life care is so absolutely vitally important for our residents, and it's something that we need to advocate for. How do you feel about that, Paula?
Yeah, I'm fully with you, Zeta. I'm fully with you.
Thought you would be somehow. I don't think I've got anything else that I'd really like to say, but anybody who is thinking of rolling out either electronic care plans, you're going to go through pain before you get to the end result, and it is worth it at the end. Anybody thinking of rolling out PainChek within electronic care plans, again, it's how you sell it and present it to your team. It's how you show them what the benefits of it are, and if you're signed up to it, the team will pick that up off you, and that's absolutely fine. And don't be frightened of it, because AI, there's been so much in the news recently about AI and all the stuff that's going on in America with all the socials and all that type of thing. This is where it works really, really well, because it's giving those very slight cues that you can't always pick up. And it's really quite clearly evidencing that this is something that's really, really positive. And I'm sure as we move further on, there'll be more things like this coming along. And it's not going to replace our jobs. This is a big thing. Is AI going to replace our jobs? It's not going to replace our jobs in this respect. It's an adjunct to it. And it's a tool that gives us something to very, very clearly evidence what we're saying to prescribers and also people who manage people's care from a social perspective. And I personally think that's really powerful.
Zeta, can I jump in? It's more of a statement, right? Or a question to you, especially. You've gone through this process of integration. You've gone through using PainChek with Care Control. Firstly, I love the passionate way you talk about and describe this. So for me, seeing this transformation that you've gone through and seeing, I suppose you talked at the start of this conversation about using old pain charts and that being quite subjective, right? So that's based on people seeing and believing what they've got in front of them. Moving to this digital platform, right, where it takes away that subjectiveness. How would you describe that transition for people that are actually administering this product? How would you describe the team, your team that went through that? What was their behaviors like? Did they feel uplifted? Was there trepidation? How did that transformation work for you?
Had different we had different things in different care homes. One of our care homes was we're having our nurses doing it and our nurses are doing it, and I didn't want to go with that, and that's what they started with, and then it's branched out from there. In some of our other care homes where we've got very engaged carers, as Paula was talking about, who want to learn and grow and develop their roles, they just took to it like a duck to water. In one of our care homes, it was like, well, hey, look at this, yeah, and they were sort of like, really interested in it. So I think a lot of it is how it is led by the manager in the home, and what type of service it is. We have very different services. We have some services that are very, very general healthcare, end of life focused, and we have some services that are mental health and dementia focused, some services that are a mix. So some homes have embraced it and it's just run.
Fabulous.
And I'm going on and checking, because obviously I get an overarching picture of what's happening in the homes. And I can see, oh, that's a care assistant, that's a senior care assistant, oh, that's a nurse, that's a, so you can see that integration. So mixed, but I think that's health and social care, isn't it? It's very, very mixed. The couple of homes that set it off recently, they think it's easy, they love it, they actually feel it saves time in the long run. And also, as Paula was saying about the quality statements, it shows very, very clearly that we're looking at it from a whole perspective. I know Tandeep said it takes a couple of minutes. It doesn't even take that, to be fair. It doesn't even take that.
Instant, yeah.
Yeah, well, it's not quite instant, but as people get over
in the new scheme, compared to doing the old pain charts, it's radically, in terms of the percentage you gain back, right, must be hugely beneficial.
It is, absolutely. And I think because it is on an app and it's in their pocket and they've got Care Control in their pocket as well, it makes it easier because they're not having to go to the MAR chart, go and find a pain chart. It's all just there and they just click on it and go.
Fabulous. Some really clear benefits there around the quality care that we were able to deliver from this. So thank you so much, ladies, for talking about that. Obviously, we're just gonna kind of, I suppose, frame that and bring everybody into this discussion now around, how this, especially Paula, because I know this is an area you're passionate about in terms of CQC, how it fits. You've already mentioned some of those statements where it fits. We had 50%, I think, on first one, 5 out, 4, 5, and you were talking about numbers. Let's just talk very briefly about how this fits in, and in terms of the safe, the care, and well-led, responsiveness, effective. Is there any commentary you want to add around this, maybe areas that we haven't covered off about how this fits under the CQC quality? Paula, I'll lead with you.
Yeah, I'm pleasantly surprised how one app doing one thing that you may think, oh, I don't want another app just doing one thing. I need to incorporate hundreds of things. Care Control is excellent at what it delivers in its care planning, in its risk assessment, in all of its audits. It's absolutely fabulous. One of the reasons I'm very happy to endorse Care Control as a care planning tool is because of its comprehensiveness. With PainChek, sometimes people look at it and think it's a one-off thing. I'm not going to invest in that one-off thing. But for something that just checks pain, it absolutely covers all of the key questions. There are quality statements that it will go into, the I statements, it will support with the I statements. I'm treated with dignity and respect. As Zeta says, you're not going up to somebody at each medication round saying, what's your pain like? Where's your pain? And having a full-blown confidential conversation at the medication trolley. You can have that quick press of a button to assess, and then you have far fewer questions when you're asking about analgesia. So from a quality perspective, it's obviously a very good tool, and it gives excellent feedback, which again, as Zeta says, has a real knock-on effect within the environment. If you're managing people's pain, you will be managing a lot more as well.
It's as what you say, Paula, isn't it? It's about understanding and trying to rule out causes of distress behaviour, because distress behaviour is an unmet need. And an unmet need can be physical, it could be psychological, it could be spiritual. It's an unmet need, and we need to understand what that unmet need is, which I think, you know, as you say, it goes across everything, doesn't it? Really, it goes across all the key line. Don't have key lines of inquiry anymore.
Key questions now.
Key questions now.
Yes.
And it, like you say, I think it's very reassuring that it sits within all the 5 main domains.
Thanks, Zeta. Thanks, Paula. Tandeep, from your perspective, is there anything you want to touch on around the quality statements from our PainChek?
I think it's it goes back to what Paula said earlier. Really, is around PainChek is guess more than just an app. You know, it's driving outcomes. It's supporting various quality statements. But for me, PainChek is a system, right? So it's the app. It's the point of care application that really helps the carer, empowers the carer to do assessments there and then, and to Zeta's point, in discrete way, but it's there and then. We're not having to sort of wait for a nurse or wait for a senior to come and do an assessment. We can do it there and then when it's needed most. So responsive is really key here, from that respect. The analytics, the data, we talk about data, but data is only good if it makes sense and if it comes together. And I think what we do through PainChek is provide the portal, the data analytics portal, which supports with not just identifying pain trends over a period of time, so it helps with decision making. But actually, one of the unique areas is we're collecting data on individuals here, so we can individualize pain management, okay, by really identifying how an individual's in pain cues differ from one another. So you can develop, profiles on individuals and really understand how that individual communicates their pain, because the way I would communicate my pain may be different to Zeta. We're all individual, and it's a highly personal experience, pain. So therefore, we need to be able to support us driving better decisions by individualizing it. And, when we talk about person-centered care, this is what it's all about. It's about individualizing, but it's also about really understanding, and something that Paula mentioned earlier, and Zeta, was around, being able to rule in, rule out pain, so you can kind of really understand what's going on underneath, because it's not just pain that may be causing the distress. There may be others, but unfortunately, sometimes we just can't get past that first base, which is this person in pain or not? So truly person-centered care is really understanding the person living behind the dementia. And that's probably where I leave it.
Thanks, Tandeep. Great stuff. I think just kind of we're coming to the close now of this particular webinar. I think for me, some of the key takeaways from this conversation, it's been super informative, and I'm sure we all agree that particularly the people on the call, I always learn something when I speak to you guys. It's fabulous to just hear your experiences, all of you, from your backgrounds. It's super powerful as well for our audience. I'm hoping that the people watching this absolutely understand the fact that actually we'll see massive benefits if they want to use both Care Control and PainChek as an integrated tool. That for us is the benefit that we're looking for. We want to bring this quality care to people's doorsteps. So the data, the transformation around managing people's pain, all of this is fantastic. And I hope that for you, the audience that have been watching today, you've learned something and you're keen to progress. So for me, on behalf of the Care Control team, PainChek, Paula and Zeta, I just want to say a massive thank you for joining us today.
Thank you very much.
Thank you.
Thank you.
Brilliant. Thank you, Marcus. Again, thank you very much for joining us today for this very insightful session. I know I've learnt a lot, and it's always great talking with you guys. You're very knowledgeable people, and it's great to share this with everyone. I want to say a special thank you to Paula and Zeta for your contributions today. It's been a pleasure having you with us. On behalf of the entire Care Control team and PainChek, we want to say a huge thank you. To our viewers, we hope that today's webinar has been informative and insightful. For those of you who have signed up, please be on a lookout in your inbox for further information related to today's topics. We'll be sharing details on PainChek, Care Control, and a link to Paula's business, Achievable Care Quality. If you'd like to stay up to date with all things tech and care related, please follow us on our social media platforms, which we will have linked in our description below. Again, thank you for joining us, and if you have any further questions or you'd like any information, please contact us at sales@carecontrolsystems.co.uk. Thank you for tuning in.